Thank you, Mr. Chairman, obrigado. And thank you to AstraZeneca Brazil for inviting me to your conference. It's very nice to visit Brazil and to see how active and vigorous psychiatry is here. I'm currently Director of the Institute of Mental Health in British Columbia, which is in Canada. You may have heard of Vancouver. It's one of the few parts of Canada that doesn't freeze up in winter. And here I'm going to talk to you about update on new therapies in bipolar disorder. Now, bipolar disorder has so much information coming out that I'm being rather selective and focusing on pharmacotherapy. These are my disclosures. I do lectures, paid lectures for various drug companies. I sit on advisory boards. I have research support from the Stanley Medical Research Institute, the MRC, the Canadian Institutes, and NIH. And also we benefit from numerous private donations. I'd also like to take this opportunity to advertise the forthcoming conference in Vancouver. The International Society for Affective Disorders is there in April 2010. This is a picture of Vancouver here. As you can see, it is very lovely. And I know that the same year has the International Society for Bipolar Disorders in Sao Paulo, but we have an agreement that if people from Brazil come to Vancouver, everyone from Canada will go to Sao Paulo. So that should be a deal. My objectives today are to review very briefly bipolar disorder and particularly the importance of subtypes or phases of the illness. And then I want to talk about treating mania, depression, and the very important issue of preventing relapse. Bipolar disorder is an underestimated and disabling condition. The key reference is Meringus here for the epidemiology. This was published in the Archives of General Psychiatry last year and shows the lifetime risk in North America for bipolar 1 with mania, bipolar 2 with hypomania, and the broader clinical spectrum. So if you just look at bipolar 1, it's 1% lifetime risk, about the same as schizophrenia. Bipolar 2 is another 1%. And then the broader clinical spectrum, bipolar spectrum, about another 2.5%. So this is a very, very common disorder. It is ranked 6th highest as a cause of disability in the WHO studies, higher than schizophrenia and obsessive compulsive disorder. And there are very significant consequences for the patient, the family, and society of having bipolar disorder. Episodes are, of course, devastating for the person's interpersonal relations. People die, on average, about 10 years earlier than they would otherwise. Most of the deaths are due to the common killers, such as cancer and heart disease, although there is a significantly raised risk of suicide. And of course, there's a big cost to society, not just to the individual and the family, but the costs, the economic costs to society of this illness are very large. The reason that bipolar disorder is so fascinating to clinicians is it is a complex and multidimensional illness. It is one of the few illnesses in medicine that can present in almost opposite ways at different times. So of course there are episodes of mania or hypomania, but importantly there are also episodes of depression. And whilst we've tended to define the disorder by mania or hypomania, it is now quite clear that the bigger burden of illness is due to depression. The other real problem with bipolar disorder is it is a relapsing and recurring disorder with an average or a median of 10 episodes during the person's life. The need for maintenance treatment is really quite clear. Recent studies show that patients are symptomatic for almost half the time on prolonged follow-up. These are two studies, the NIMH Psychobiology of Depression study by Judd, looking at bipolar 1 and bipolar 2, and the Stanley Network studies by Ralph Kupka, which looked at Stanley centers in North America and Europe. And the Judd study looked at patient diaries for about 13 years, and the Kupka study looked at life charting for a year. And the headline result is true for both studies. Patients are only symptom-free for about half the time. So you can see whether it's bipolar 1, bipolar 2, bipolar 1, bipolar 2, the amount of time without symptoms is only about 50% of the time. The second point is that the most common symptoms, even in bipolar 1, are depression. So by about 3 to 1. So depressive symptoms really are the big issue, and I think they're actually far more toxic to the brain, partly because they're so prolonged, than the episodes of mania. And we'll hear from our other speakers about the neurobiology of this related to things like BDNF. So that's a very brief few words about the illness. I'd now like to go on to talk about the therapies and specific treatments of specific episodes. Again, one of the very interesting things about bipolar disorder is we use almost every therapy that's available in psychiatry for the treatment of bipolar disorder. And in actual fact, we even take therapies from other medical disciplines. For example, the anticonvulsants. ECT still has a role in treatment of both mania and depression. Lithium, which was reintroduced to medical practice in the 1960s after Cade's discovery in 1949, is still used very widely, and we're still learning new things about lithium, and indeed I'm going to show you some new data about lithium today. The antidepressants have been used for decades in bipolar disorder, but very often on the basis of no evidence. And of course, the antipsychotics are widely used. In many countries, there are more antipsychotics prescribed for bipolar disorder than for schizophrenia. This graph illustrates why clinicians like treating acute mania with antipsychotics. It's for Seroquel, but the same would hold for every other atypical. So basically, we can see the atypical versus placebo. There's an early onset of the effect, which tends to be earlier than treating with other anti-manic agents like lithium or valproate. Not only that, but you can see that the placebo effect tails off, whilst the anti-manic effect of the atypical builds up over weeks. I don't think there's any difference in efficacy between the atypicals as anti-manic agents, as long as they're used at the correct dose. And remember, in psychiatry, we have a long tradition of getting the dose wrong at first. So for example, with aripiprazole and risperidone, we dose too high. With Seroquel, we tended to dose too low. But if you dose at the appropriate level, they're all broadly similar as anti-manic agents. It's also true to say that if you add any of the new atypicals to lithium or valproate, you get extra anti-manic efficacy. And you can see that illustrated here. The one exception is my colleague from Vancouver, Professor Yatham, published a study where risperidone was added to lithium, valproate, or carbamazepine, and when the carbamazepine group was included, there was no benefit, but this was because carbamazepine, by inducing metabolic enzymes in the liver, had reduced the levels of risperidone by 70%. So with that exception, if you do co-therapy, there's usually extra anti-manic efficacy.